don't underestimate how impressive those pictures are. But he has stolen the clicker.
One's mine, one's yours. That one's yours.
Thank you. So we're going to talk about the assessment of management of acute rhinosinusitis, and in particular cases associated with the complication. So acute rhinosinusitis is generally managed in primary care, and as ENT surgeons, we won't often get involved in management unless you happen to be at the school gates, your parents phone you up for advice, or you want to do some private practice. But it is important to have a good basis of knowledge so we can back up our primary care colleagues. We need to know how to manage orbital complications because of the consequences of getting it wrong and because it's very commonly asked in the exam. And we need to know how to deal with our neurosurgeons in the middle of the night. So we need to know a little bit about intracranial complications. So I don't drop my kids off at school anymore because every time I do, I'm presented with a child that looks like this and an anxious parent wants advice on how to manage it. So acute rhinosinusitis is really common and we will all come across it. The textbook definition is sudden onset of 2 or more symptoms of nasal obstruction or discharge with facial pain or anosmia. Now, I think this is a bit oversimplified, and essentially it's purulent discharge that's key, with acute blockage, often dental pain and pressure, and patients feel unwell. It should last for less than 4 weeks. And to try and differentiate it from a common cold, the EPOS guidelines give an idea of acute post-viral rhinosinusitis. And typically, patients will have a cold for about 5 days, but they will describe suddenly getting worse, this concept of double sickening, where the change goes from rhinitis, viral infection, to affecting the sinuses. So anything where you get double sickening at 5 days, or if it lasts for more than 10 days, we can describe as acute post-viral rhinosinusitis. It's very common. 6 to 15% of the population will have one episode every year, and it accounts for up to 10% of visits to GPs. But a very small percentage are thought to be bacterial. Recurrent acute rhinosinusitis, which we'll come back to, is actually astonishingly rare. It's more common in the winter, more common with high levels of air pollution, more common in smokers, and in patients with allergic rhinitis. And it's very difficult to pick out which ones actually have a bacterial rhinosinusitis. We would want to know so we can identify which patients are most likely to benefit from antibiotics, but we're simply not very good at it. So if you have obvious purulence, you've still only got a 50% chance for positive bacterial culture. If you have unilateral facial pain, it doesn't really help, 40% positive bacterial culture. Fever doesn't help us at all. If you have combinations of symptoms, so you have purulence in the front of the nose, down the back, clear double sickening, raised inflammatory markers, you've still only got an 80% chance of it being bacterial. But the more signs and symptoms you have, the greater the likelihood. The gold standard is a maxillary aspirate. That's almost never used except in research studies. If you really want to be sure, you can take a guided osteomeatal culture. So you take a swab in a sort of a little guide so you don't brush the anterior nares, and you take your swab directly in the middle meatus. But in everyday practice, we hardly ever use those investigations, and they're only really used, as I said, in research studies. You would only use them really if a simple episode fails to resolve, in which case you might consider a full blood count and an ESR and a guided swab if microbiology is very important. CT scan doesn't really have any useful role because, as a classic paper by Gwaltney in New England Journal of Medicine showed, patients with a common cold also have quite extensive changes on their CT. So you only use a CT if you're looking for complications of acute rhinosinusitis. So what's the evidence-based management? Well, I think we can confidently say that antibiotics are not indicated in the management of uncomplicated acute rhinosinusitis. There was a Cochrane review published last year, and we have really good, high-quality evidence. We have 15 randomized controlled trials now with over 3,000 patients. 50% of patients are better at 1 week in both arms, 70% at 2 weeks, and that's important. So our patients shouldn't expect to feel better at a week. Most patients take 2 or 3 weeks to recover from their acute episode. That doesn't necessarily mean that they need antibiotics. Now, there was a small clinical effect for antibiotics. 5 out of 100 patients get better slightly more quickly in the antibiotic arm. So that means we need to give 18 patients antibiotics for 1 to benefit. It's a pretty small effect. And the difference is about 4 hours in terms of speed of resolution. So, they're really not doing very much. When we look at adverse effects, however, 13 patients out of 100 get significant gastrointestinal effects. So we only need to treat 8 patients with antibiotics to harm 1. So we're twice as likely to do our patients harm by giving antibiotics as we are to make them feel better. We've also got to consider increasing antibiotic resistance across the whole population. And we've got no evidence that it reduces the risk of complications. So, this is pretty strong, high-quality evidence. The NICE guidelines back that up. 2017, they said do not prescribe antibiotics except in the presence of patients with cystic fibrosis, immunosuppression, or significant comorbidity. If something goes on for more than 10 days and you think you need to use antibiotics, penicillin should be the first choice. I'm not actually sure about that because resistance profiles would suggest that penicillin is not likely to do much. I suspect that's a placebo effect more than anything. And we should change to coamoxiclav if there's no improvement after 2 to 3 days. But it does, again, support the significant risk of adverse events. As I said, there's no evidence it reduces the risk of complications. If you look at countries with very low rates of antibiotic usage, their rate of complications of acute rhinosinusitis is 3 per million. If you look at the US, where the rate of antibiotic usage for acute rhinosinusitis is 10 times higher, the risk of an acute complication is just the same. And again, a UK audit showed that 50% of patients who had a complication had already been treating with antibiotics anyway. But 87% of GP consultations going to a GP for acute rhinosinusitis end up with a patient walking out with antibiotics. And they account for 1 in 5 of antibiotic prescriptions in the UK. So this is a massive burden for antibiotic resistance. And I've shown this slide before to the faculty, but this is why. My mum is a fairly typical patient. However, she also used to be a medical microbiologist many years ago. They had discovered antibiotics in her time of practice. And she phoned me up and said, I've got terrible viral sinusitis, so I insisted the GP gave me penicillin. That is wrong on so many levels, but that is the pressure our GPs face on a daily basis. Our GPs know the evidence. They're aware that antibiotics don't make patients better, but they're under enormous pressure from patients to receive antibiotics. So we really need to support our GPs and back them up. If a patient comes in with a complication, we need to reassure the patient that antibiotics wouldn't have avoided it and so on, so that our GPs feel supported in trying to resist this. I hope my mum is not watching this on live screening because she'll probably kill me. So what else can you do? Well, Cochrane review of intranasal corticosteroids does show some benefit. The actual clinical effect is relatively small. So the relative risk is 1.1. It's only slightly better than placebo, but there is some evidence that it reduces duration and severity. So an intranasal corticosteroid is not a bad option. The number needed to treat is 15, so they're really not doing very much. But they are recommended in the NICE guidance, and I suspect it's probably as a tool to help GPs avoid antibiotic prescription. Patients want to go home with something. It is probably safer and more effective to send them home with an intranasal corticosteroid than it is with a prescription of antibiotic, and it might encourage patients to wait for a delayed prescription. Systemic corticosteroids, slightly more effective. Risk ratio of 1.3 compared to placebo. There's an increased cure and symptom improvement rate at both day 3 and 7. There were no differences in adverse events in the trials in the Cochrane review, but obviously it's a small trial. They're not recommended by NICE guidelines, I think probably because of the risk of adverse events. But in my private practice, if a patient comes to me with acute sinusitis, this tends to be the thing that makes them feel better. Decongestants make patients feel better. I would certainly encourage usage just again to avoid antibiotics, simple analgesia, and you might consider Sinupret, which is an over-the-counter herbal remedy that has some evidence to support effectiveness. This is the EPOS guideline that effectively puts that all into an algorithm. So mild cases, less than 5 days, really encourage conservative management. Moderate cases or persistent, consider intranasal corticosteroids. Reserve antibiotics for severe cases that haven't resolved. If things are still not getting better, or there are any of these red flag signs, eye signs or neurological signs, then you need urgent referral. If things really are not getting better, you might consider steroids, decongesting the nose and admitting for IV antibiotics. These are the cases where you want to take a swab to look at what bacteria are involved, and you may rarely consider surgery to wash out or drain the sinuses. I have to say it's very uncommon for us to operate on a patient with uncomplicated acute rhinosinusitis. If you do need to, then if you operate in an acutely inflamed area, particularly the frontal recess, there's a high likelihood of stenosis afterwards. So you might simply convert a patient to iatrogenic long-term disease. So you want to do as little as possible. So this is probably the only place where I think a balloon has a really good use. You can balloon the frontal sinus or consider a mini trephine if you need to deal with an acutely infected frontal sinus. Children are slightly different because of the sinus development. So maxillary sinuses are present at birth. The ethmoids grow up until the age of 7, but we only really get frontal sinuses and sphenoid sinuses later on. So early childhood, it tends to be maxillary and ethmoid disease. The diagnosis is more difficult because there's a huge overlap with adenoiditis. It's chicken and egg. We don't know if the adenoids feed the sinuses or vice versa. They often get a cough more than they complain of postnasal drip or catarrh, but the treatment is the same. Antibiotics are still only indicated in severe cases or in the setting of complications. Recurrent acute sinusitis is actually very rare, and a lot of patients will actually have an acute exacerbation of underlying chronic rhinosinusitis. If a patient truly has recurrent disease, I consider immunodeficiency. I do screening blood tests if there are any other history of infections, bronchitis, skin infections, kidney infections, so on. You want to treat the allergic rhinitis, get the patients to stop smoking because we know that these are risk factors. And most importantly, you need to see or scan the patient when they're acutely unwell. If you have shown it to definitely be recurrent acute sinusitis, there is a role for preventative surgery if a patient gets more than 4 or 5 episodes a year, and there's some evidence to support that. But that's the key thing, it's making sure that a patient really has acute sinusitis. There was a really nice study by Richard Harvey's group that looked at over 40 patients who had been referred with recurrent acute sinusitis. Both the primary care physician, the referring ENT surgeon, and the patient were all convinced that they were getting 4 or 5 episodes of recurrent acute sinusitis every year. They had a normal CT scan at diagnosis, at referral, out to an acute episode. Typically like this is a patient sent to me who'd had 3 scans elsewhere, recurrent episodes, but they were normal on every occasion. The problem was that none of them were done when the patient was acutely unwell. So in the Harvey study, they brought the patient back and re-scanned them when they were acutely unwell, and 41 out of 42 of them still had a normal scan and were thought to have recurrent facial migraine. Only 1 out of that 42 actually had evidence of acute rhinosinusitis on a scan. Now in the NHS that's really difficult, but it's still really important. So this lady, I was about to sort of tell her that she had recurrent facial migraine and send her away, but I asked our radiology department if they would fit her in because of the difficulty making the diagnosis when she was unwell, and these were her scans. So the difference in the 2 scans, same patient, during an acute episode and when she's well, and that's why it's so important, the timing of the scan. So these patients are relatively small in number, and it's worth having the conversation with the radiology to try and get them scanned at the right time. She had mini-fest surgery, and when you look at the risk factors anatomically, it's obstruction of the osteomeatal complex, so a large concha, an elongated pneumatized uncinate, stenosis of the infundibulum, and therefore you can have relatively conservative surgery to open the osteomeatal complex, an uncinectomy, antrostomy, open the bulla, and that seems to be quite effective in reducing the frequency and severity of recurrent acute rhinosinusitis. Complications of acute rhinosinusitis. They are relatively rare. There are about 200 cases per year, or 3 per million of the population. 3/4 of them take place in kids, 1/4 in adults, and the vast majority are orbital. Now, warning symptoms are eye signs and neurosigns, periorbital edema, displacement of the globe, double vision, ophthalmoplegia or pain on eye movement is a really useful early sign. Any reduction in visual acuity, reduction in red vision, colour vision goes first. Any neurosigns such as headache, meningitis, neurological signs, reduced level of consciousness, or significant frontal forehead swelling. And all of these are red flag signs that make you want to think about a complication. So orbital complications, again, the vast majority in young children. It almost always is direct spread from the ethmoid sinuses. And typically, you get to see these patients at about 5:30 on a Friday. They will always have seen the GP earlier in the week in the eye clinic. They will have been on the paediatric ward. And just as everyone's going home on the weekend, they decide it's probably a good time to call ENT because the eye hasn't got better. Healthy eye on the other side, red eye, swelling, puffiness. Now, Tim's right, we always talk about cases that have come from elsewhere, and I apologise for that, but these are 2 cases that have been referred to me in the last 3 months. So one is a 5-year-old child. He was admitted elsewhere, and on admission, the pupil was noted to be dilated. He had a subperiosteal collection on the CT scan and was taken to theatre for some kind of endoscopic procedure. It's not quite clear what happened, but from the CT scan, not very much. He had an antral washout, perhaps, and was given antibiotics. Now, the eye hospital was a separate hospital, and The ophthalmologist therefore didn't come and visit the child wasn't sent, and so therefore he had no formal assessment of his vision for 5 days, despite having a dilated pupil. The eye remained very swollen, and eventually they gave a dose of steroids that was so high it put him into a hypoglycemic coma, and so he was transferred to our paediatric neurology ward. The scan at that point showed clear optic neuritis, and on assessment he was completely blind in that eye. We took him to theatre that day, did a full FES and endoscopic decompression of the orbit and the optic nerve, and the next morning he had finger counting, but 3 months later there's been no further improvement. So this is not the way to manage a child with orbital cellulitis. There are key things, no matter where the eye department is, they need to come and formally assess vision. If there is a dilated pupil, that needs urgent, aggressive treatment. There is clearly something going on. There was perhaps an opportunity to save vision right at the beginning. Who knows? It's quite possible the child would still have been blind if we'd had the chance to operate at this point. But that's a missed opportunity. This is another case that came from elsewhere. The eye was so swollen in this 45-year-old male that the referring team simply couldn't assess the vision. They couldn't get the eye open enough to see whether there was anything going on. They did a CT scan, which didn't show any obvious collection, but they were concerned enough that they took the patient to theatre, they did a washout and an ethmoidectomy before transfer and started the patients on IV antibiotics. So they did everything they could to make the eye safe before sending to us. We treated the patient for 48 hours with IV antibiotics and had twice daily ophthalmology review and ENT input. And on the third morning, it was noticed that there was a very slight reduction in red colour vision, so the patient was taken straight back to a CT scanner. The scan was looked at while we were in theatre, while the patient was still on the scanning table, and there was significant swelling of the superior muscles to suggest superior ophthalmic vein thrombosis, which very rapidly progresses to Cavernous sinus thrombosis. So the patient was taken from the CT scanner. I happened to be operating at that time and brought straight into theatre. Because of the delay from the scanner and getting the patient on the table, we thought we should do a lateral canthotomy and then did a full orbital decompression, and the patient had complete recovery of vision with no long-term sequelae. So everything lined up perfectly. I happened to be in theatre. The patient was picked up first thing in the morning. We could get the patient straight into the scanner, and we were lucky in many ways. But this is what we should aim to be doing for these patients. So you can guess which case is unfortunately going to the lawyers at the moment. And for that 5-year-old child, he's blind in one eye. It's a terrible outcome that might have been avoided. This was the patient that we managed to get to theatre. You can see that he's actually probably got an odontogenic acute rhinosinusitis, so it was a very virulent, aggressive pathology. And on the original scan, there's only a little bit of swelling of the superior rectus muscle. But on the next scan, this is the superior oblique that's now very swollen. It looks a little bit like a collection, but it's actually just an engorgement of the muscles because the ophthalmic vein is thrombosed. So there are subtle signs, but the key thing was his red vision went off very quickly. This is the lateral canthotomy, and we should all be able to do these. This is a sight-saving procedure. It takes about 2 minutes and heals without a scar. And then we went and did an orbital decompression. So as an overview, careful eye examination. If you can't examine the eye, if you can't assess vision, you need to treat more aggressively than if you've got the reassurance that vision is normal. And reassess regularly. If there are any eye signs, you want an urgent CT with contrast, and urgent surgical intervention if there's a collection, or if you're simply concerned that there's a visual abnormality in the absence of a collection. Again, I would consider doing something, lateral canthotomy, orbital decompression, just to try and prevent a build-up of pressure. If the patient doesn't get better, even if they've had a normal scan on admission, have a low threshold to re-image because things can progress. Now, ENT UK have actually published a guideline on orbital cellulitis in the last 6 months. I have got some photocopies to hand out. I have to apologise, the quality of the photocopy is not very good. But if you put into Google SSO, specimen standing order, I'm not quite sure what it's called that, ENT UK and cellulitis, you can download this directly from the internet. Now, this follows, and it may be difficult to read, but much the same thing. So a patient with preseptal cellulitis, you can probably manage conservatively. Anyone with more severe changes need to be admitted. They recommend IV tazocin, but you might want to liaise with your local microbiology department. If the patient is immunocompromised, then they recommend more aggressive treatment with steroids, indications for imaging in the presence of any eye signs, failure to improve or an inability to assess the eye, and if there is a collection, they would advocate surgical management. So in terms of the exam, you all need to know the Chandler Classification. I don't think it has any useful clinical role other than that because they don't really progress from one to the next. But you do need to know that there are 5 classes described by Chandler. The first is simply preseptal oedema. Second is orbital cellulitis without a collection. The third is a subperiosteal abscess. Fourth is an orbital abscess. And the fifth is cavernous sinus thrombosis. So they don't necessarily, as I said, progress in a stepwise manner. So preseptal edema is by far the most common. Puffy eyelid, but if you open the eye is normal eye movements, no other signs. On the CT scan, there's no enhancement of the fat, the muscles aren't engorged, there's no proptosis, and all the swelling is anterior to the orbital septum. So the next question that you get asked in the exam is, okay, so what's the orbital septum? Well, it's an extension of the periosteum from the orbital margin and the levator. It inserts into the tarsal plates at the lid margin, and the key thing is it forms a complete diaphragm that encloses the orbit, so there's no room for any expansion if you have a post-septal collection or edema. So patients with preseptal cellulitis may be managed as an outpatient if you've got access to an eye clinic or rapid review. Medical management, including broad-spectrum antibiotics, and there is no role for surgery at this stage, but they may need to be re-evaluated. Orbital cellulitis, this is now inflammation behind the orbital septum, so within a confined space. And you can see that there's already significant chemosis of the globe. And on the CT scan, there's no collection, but there's engorgement of the muscles and enhancement of the fat. There is perhaps a little bit of intense signal on the optic nerve, which might signal optic neuritis. So this group, there's no collection, but they still need aggressive management. You need ophthalmology input, and in some cases, you may still want to decompress the eye to take the pressure off, and you may well want to drain the sinuses to remove some of the source of infection. Subperiosteal abscess is where we're most likely to play a role surgically. Here, the collection has been a direct extension from the ethmoids, so it tends to be on the medial wall. You'll often get painful ophthalmoplegia, and again, early loss of colour vision. So it's useful to have Ishihara charts on your iPhone or smartphone if you've got them. That's a very quick way to assess colour vision. You might also get a relative afferent pupillary defect. And again, next question in the exam is, okay, what's that? Well, the easiest way to test for it is you put a flashlight in the normal eye and both pupils will constrict. You then swing your flashlight across to the affected eye and you'll get a dilatation because you've got a relative afferent pupillary defect. So you swing the flashlight from side to side. I'm sorry that the video won't play, but this is a pupil that was dilated with the light on the other side, and as you bring it across, it constricted with the light in the other eye, and then it dilates as you bring the light across. You need a CT scan with contrast enhancement, and then you see this subperiosteal collection just coming up as a little crescent. You can see the periosteum lifted up and this small collection on the medial wall. And they can occur in other places, so don't be caught out. They can be superior, right on the roof, or very rarely on the floor of the eye. But you see the same sort of pattern on each of those with a nice crescenteric lifting of the periosteum and a collection underneath. And the management of these, particularly in any exam, is drainage. And drainage by whatever means you can do safely. So in the majority of hands and in the majority of cases, the safest way to drain these is externally. I would rather have a scar on my face than a blind eye. And the scar should be stepped, so you can see that there's a small step here to prevent webbing. And then when you close it up, you leave a couple of drains in. It's not a particularly cosmetic scar, but so if you can do it endoscopically, safely and adequately, that's ideal. But as I said, a scar is better than a blind eye. Endoscopically is difficult. These patients are acutely infected. The mucosa is very edematous. You need lots of decongestant. And I still find them challenging to do endoscopically. So I will always consent to do it open. Probably 75% of the time plus I can do it endoscopically. But you have to do a full ethmoidectomy. You have to lift the lamina up to get to the collection. So it's quite extensive surgery in a difficult field. You want to do whatever is safe and make sure that you let the pus out. Now, the management of subperiosteal abscess is conservatively is very controversial. It is not included in the guidelines of ENT UK, and I did question that. What if someone decided to manage a collection conservatively and it went wrong? It would technically be against the guidelines. The key thing is if you're going to manage it conservatively, there is some evidence to suggest you might be able to do in children who are young kids, under 9, with very small volume collections, so less than 4 millimetres of collection. There is some evidence that actually with conservative management, they might do slightly better, but you have to monitor them very, very closely. You need regular ENT and ophthalmology review, and you need the ability to get them straight into theatre if conservative management doesn't go well. So it's probably only going to be indicated in very selective centres. But we have quite a reasonable number of children who we have managed conservatively with good long-term outcomes. And that's one of the papers suggesting that it might be possible. The key thing is small volume abscesses where you can carefully monitor these children. But that's very much in the small print, and I probably wouldn't mention it in the exam. Orbital abscess, you're now in trouble. There is a collection within the cone of the eye, high risk of blindness and morbidity. You want to manage these patients very aggressively with your eye surgeons. You need to go into the eye to get this abscess out. And as I said, there's a very high risk of long-term blindness. Cavernous sinus thrombosis is fortunately extremely rare. I think our patient with our superior ophthalmic vein thrombosis may well have gone that way without treatment. And essentially, it spreads to the superior and inferior ophthalmic veins. There is very high mortality, even now, 1 in 3, and very high rates of morbidity. These patients progress very rapidly from admission to being really quite unwell. So this looks awful. I've seen patients with this on both eyes, and essentially they go from this to dead within 4 hours. Significant eye signs, meningism, sepsis, cranial nerve involvements. You're going to need an urgent scan, whether that's a CT or an MRV. It doesn't really matter, whatever you can do to scan the patient quickly. You can see the thrombosis on both sides here with sphenoiditis. And again on this patient. The sphenoiditis is resolved, but you can see extension here. These patients are usually very sick. They need IV antibiotics, microbiology input, supportive care in ITU. You want to drain the affected sinus if they're well enough to get into theatre. And there is some role for anticoagulation. It's still very controversial. We discuss it with our haematologists on every case, but more often than not, and when we've had patients with this, we have anticoagulated them. They tend to do quite badly, so you want to be on top of it and get as many people involved as possible. So in conclusion, for the management of orbital complications, if there is any doubt, you let the pus out. Intracranial complications will largely present to neurosurgeons, so we're not going to be so much involved in the diagnosis, but we're often involved in managing the sinuses. They're commonly associated with other complications. So 10% of patients with orbital cellulitis will go on to develop an intracranial complication. Again, so if the patient isn't getting better, re-image to see if something else is going on. They're more common in adolescent males, particularly in the Afro-Caribbean population, and often through direct extension or hematological spread. The prognosis used to be awful, and the mortality is now down to 4%, but they have significant long-term sequelae. So again, they often need aggressive management from a neurosurgical point of view. They can present with meningitis. And just one minor note on that, this has caught us out a few times. Not all patients with meningitis who have changes on their CT scan have sinogenic meningitis. CRS affects 10% of the population, so there is a chance that some patients with meningitis will have coexisting CRS, and that can be quite difficult to be sure. So it's worth looking back to see if you've got any pre-existing CT scans, any history of known sinus disease, before you rush in, assuming that the sinuses are the cause. Extradural abscesses are often missed. They're indolent. There is direct extension, typically from the frontal sinus into the extradural space, and they often present late with confusion. Here you can see how the frontal sinusitis is resolved, but the extradural abscess is left behind, and again, direct extension from a sphenoid. Intracranial abscesses often present with fitting, focal neurological signs, rapid loss of consciousness. They'll be picked up on a CT scan with contrast. And you can see nasty frontal sinusitis with an indirect spread via the vascular route to an intracranial abscess. The key issues are that the neurosurgeon is going to manage the intracranial complications, but we need to make sure we don't miss them in a patient under our care with severe acute rhinosinusitis or with orbital complications. The management is to get a culture before you give antibiotics to try and help direct subsequent treatment. The neurosurgeons are always a little angry if someone has started antibiotics before taking a swab. The surgical management of the sinuses is very controversial, and we don't have good evidence to back that up. But our role is certainly in getting a culture taken and perhaps draining the sinuses. And then we usually see patients 6 weeks later and re-image to consider if they need anything to prevent further episodes. And that's a huge problem for our patients. They're very anxious about having had an intracranial complication, and they will often want to know if they're at risk of anything again in the future. So we make sure there's no underlying mucocil sinus disease that needs to be treated. And we published a consensus review in 2015, and at that time we recommended immediate but conservative management of the sinuses, for example, a washout frontal trephine. And that's still the view of the neurosurgeons, but I have to say I think in the ENT community, particularly with key opinion leaders in the States and in Australia, that view is changing. And Rod Schlosser in the States, Richard Harvey in Australia very much advocate conservative management of the sinuses, no surgery to the sinuses at all. Acute rhinosinusitis will drain out eventually, and to not treat the patients. So we're trying to look at some evidence to back that up and considering a prospective audit. But I think at the moment, most people would recommend some sort of surgical management to the sinuses, preferably at the same time as the neurosurgical intervention. And just as we said with orbital complications, you want to avoid instrumenting an acutely infected frontal sinus. So my preference would probably be the Medtronic mini trephine set, or I'd consider a balloon. And I certainly don't want to be instrumenting the frontal recess if everything is very inflamed. Finally, Pott's puffy tumour is a direct extension through the anterior table, so you get a collection on the forehead. It can be sort of chronic and subacute, or acute and infected. In the first instance, we would aspirate this now with a needle through the skin, treat with antibiotics for 6 weeks, and come back and drain the sinuses, again when they're less inflamed and infected 6 weeks later, so that we don't get a frontal stenosis. So thank you very much for your attention. I will leave you with a novel approach.
Okay. The first one is custom